I'm going to kick off by asking Deepa a question about fertility, and in particular the role of low carb in fertility. And I've managed to get a number of women pregnant. No, I shouldn't say that. I've had some success at getting couples who are having difficulty being pregnant. Sorry about that. No, I mean, for instance, I had a couple of colleagues at work come to me, the female come to me and say, they've been trying for a year, and she was concerned about not being able to get pregnant, and just looking at her, she clearly had some of the sort of hallmarks of PCOS, and her diet wasn't terrible, but it certainly was quite high in carbohydrate and so on. And I gave her a copy of my book, and she went away and was very determined. And within 3 months, she came up to me and said that she'd been successful, and they had a little baby a couple of months ago. And I thought they should have named it Peter, but it was a girl, so it made it a bit hard. But I mean, all jokes aside, I mean, I think it really, I believe, it should be the first line of treatment really for infertile couples to tackle a low carb diet. And I've been told, I mean, there's certainly some people say when you're looking for the reason is that maybe there's some chronic inflammation there that's causing inflammation of the ovaries and so on. So what's your experience with that, and how many women have you got pregnant? And and what about some of the causes and the theories behind that?
So clinically, I do see women who present with polycystic ovarian syndrome, and in that particular disorder, we can often see about 50 to 60% of women have insulin resistance. So you're correct, we should be testing and looking for this far earlier than allowing women that usual 6 to 12 month period of time that we give people in clinical practice to fall pregnant. I must say I'm a lot more proactive about going about doing that so we can identify it earlier rather than allowing that amount of time, especially nowadays since women are presenting at an older age group when they first decide to want to conceive. So we're not only battling against embryo or egg age, which will decline with time, but if there has been insulin resistance and inflammation present for a decade or more at least, then it will take some time, as I spoke about, more than just a 6-month period to reverse that sort of issue. So it can happen very quickly. I mean, like you've experienced and had those particular women who've fallen pregnant quite quickly, and in other cases it can still take up to a year, and that's sort of the issues that we have with subfertility and lack of nutrients in the diet. So I think there's so many factors at play, but we cannot overlook how significant a role insulin resistance plays in infertility, and often it's quite overlooked by many of health professionals who say, oh no, don't worry about your diet, just focus on doing everything else, and just time sex at the right time and it will happen eventually over 6 or 12 months. I think we have to be a lot more diligent with the information we provide to women.
Great, yeah.
Sorry, one other thing to say is when we reduce insulin in women with PCOS, we also see a fall in their testosterone and a rise in sex hormone binding globulin. So that in one way can also attribute to why they get an increase in fertility as well. They also end up getting a return to cycles if they've been amenorrheic for some time.
Yeah, we've previously had talks on PCOS at this meeting, and it's certainly the most common cause of infertility in young women, certainly. All right, enough of me. Let's go. Doug, on the job, good work.
Hi, I was just very curious about using CGM at the second trimester for women. I think it's a brilliant idea, but in terms of promoting it and trying to make it practical, cost is often the issue. And how did you go about offering a patient that, as far as I'm aware, Dexcom is only subsidizing type 1 diabetes? So it is costly if you're using a continuous glucose monitor, so the Dexcom or the Medtronic devices. The flash glucose monitors are cheaper, so they are, I think the last look was $105, including the postage.
And luckily in Australia, we can order them directly to the home, so a patient can go in and order those online. Now, with the subsidy, that's something new, and that's actually, thankfully, due to the work of Dr. James Mukey and other advocates, that we've had some subsidies now provided for all adult type 1 patients. So they may not get a full subsidy, but they will get at least a partial subsidy, and that includes pregnant women with type 1. As for managing diabetes in pregnancy, it's currently subsidised for women who are using insulin. So anyone who is on an insulin therapy. And unfortunately, out of that picture, that it's not subsidised. So my hope is that with a lot more advocacy, the Peters and James Mukey's of the world, that we might be able to tip it in favour of offering this. Because as I mentioned, you're going to save a lot of money in terms of hospital stays for neonates. And that's actually what tipped the argument in the UK, and where the NICE guidelines changed only very recently as a result of some of this CGM data. So spending that extra 100 minutes time in range made all the difference for the neonatal outcomes. So I think eventually, because that data will become more well known, we will then have our economists and politicians more awake to that idea. But unfortunately, it's going to be because it's a cost-saving measure, not because it's a great health outcome, which we all know that it's a great health outcome, but it's money that talks at the end of the day when it comes to being able to afford to give this to women. So at the moment, it is the women who can afford it, which is very unfortunate, and it really should be available to all women, regardless of what their financial status is like.
Great. Next.
Cool. Question for Deepa about the point about the pill being reducing nutrient absorption, I think was the point. So this question has sort of multiple arms. So one is, I might have missed it during the talk, but the mechanism of it. Two, is it dose dependent? So for example, low dose OCP versus high dose OCP versus MRT doses. And thirdly, is it dependent on the route that it's given? So for example, like LARCs versus OCP.
A lot of questions.
Remember those?
I probably won't be able to answer all of those because I don't know the ins and outs of every single one of the options, and I know there's different doses in the pills that can vary the impact upon nutrient absorption, which is usually occurring in the first part of the gastrointestinal tract. And then that utilisation really talks about the impact on folate particularly. So there is in fact actually a pill available, and I'm not sure if it's available in Australia, but it's definitely available overseas, which is folate fortified OCP. And it actually came about because of the research that showed that women who were on oral contraceptive pills had low B9 status. So it's extraordinary, though, that we have to go to that length to fortify our medications. And various mechanisms are postulated. There's nothing confirmed in the research, but the well-known change in the gastrointestinal tract because of the effect of hormones seems to be what it definitely arcs back to. Yes, and I don't know about the different forms, whether it matters which way you take the pills.
What about the route?
Yep.
Then, like...
Oh, sorry. Yeah, I mean, perhaps the route, I think with the oral tablets, it would be much higher, and that anything that's subcutaneous won't have as much of an impact, or obviously a intrauterine device won't either. Yeah.
Ron.
For Nicole, so a lot of my patients with diabetes and obesity, once they go low carb, if it doesn't quite work enough, I put them on time-restricted eating, so they're having 2 meals a day, lunch and dinner, which I've now been doing for 5 years. Personally, and I think a lot of my patients, they're not eating less calories, so I don't think they're losing calories, but I think they're eating plenty of protein. I certainly stress that, but now I'm worried, am I doing them a disservice with causing them sarcopenia? It improves their insulin resistance, so they become more insulin sensitive, and the ones who don't get enough, I then put them on 1 meal a day, and a lot of those people will end up, their diabetes becoming under control, their HbA1c is normalising or becoming non-diabetic. But are you now suggesting I could be doing them a disservice with sarcopenia?
Look, it's a good question because I think the more that I read about protein, I think we have to make sure, I mean, Finney talks about as well that there is definitely, it's still good to be doing intermittent fasting, but I think we need to make sure we're not doing it too frequently, and when we're eating that we are trying to ensure that we're eating good quality protein and that we're not, fasting 5 days a week with one meal and having a massive steak and thinking we're absorbing all that protein and being able to utilise it. In our clinic, we're lucky to have our seeker testing. So we do keep an eye on people's muscle mass, and we always still find on a low-carb diet people are naturally increasing muscle mass because they are eating more protein. But I do think we have to be mindful of how much fasting we're doing, because if you look at the research, we still need to be able to meet our protein targets to maximise our muscle. So it is the conundrum I've had, because we do a lot of fasting and I do a lot of fasting. So I think, my mindset is that there's still benefits to muscle strength, as I showed in that last study with, maintaining good quality muscle. So I think we should be still promoting fasting, because I think it's still giving us really great benefits with insulin sensitivity. But I just think we have to be mindful of still feeding the body and alternating those days and making sure, we're eating plenty of, getting our essential amino acids in, getting leucine in. When I personally started going, okay, I do quite a bit of fasting, so now I try to use like a whey protein isolate, which I'm talking to my clients about, which is pretty much like an amino acid boost with, the 3 grams of, leucine in there, and using that a little bit more in the mornings or overnight to just try and maximise muscle synthesis. So I think we do have to be careful with how much fasting we're doing, yeah.
Interesting. Yes, David.
Fabulous talks, both of you. Wonderful. This is more a comment on Deepa. I've been thinking about these women who are either prone to GDM or have GDM, but I don't see any studies that differentiate between women who have GDM and no fatty liver, or those with fatty liver, because I think they belong to a different category, and that must inform the way we manage them. And just a comment.
Don't you agree? Right. Good. Do you want to comment, Deepa?
So just to clarify, you're saying GDM with fatty liver and GDM without fatty liver. Yeah, that's a good question. I don't know if Liz Fraser is in the room, because she's done quite a lot of reading around fatty liver, but I don't know if you've come across anything around Gestational Diabetes Association. Yeah. So I can't say I've seen anything in the literature, but that's not to say it doesn't exist. I'm sure there's something on that. Yeah.
Yes.
Hi, it's me again. Figure out has to be fair. It's a question about fasting again. From what I understand, that while you're fasting, you can increase the level of growth hormone, especially during the night when you sleep, and early in the morning you get that spike. Would that sort of help to correct, I guess, the potential muscle loss or the risk?
Yeah, well, I think that's what I was mentioning with that last study, that definitely fasting is still creating positives with muscle. I think it's if there's long-term that we're not adequately meeting our sort of protein needs on a regular basis, I think that's where we'll be at risk, and where people are trying to make up for all their protein in just one big solid hit. You see OMAD happening a lot. But yeah, I think there's still benefits with fasting and muscle synthesis. But I think we just have to be mindful of, based on the information today that I've given, that that we're meeting our protein needs more frequently than not, and that we're timing it a little better. I mean, we can still eat in a smaller window and make sure that we're, getting those smaller serves in to try and ensure that we're, meeting our protein needs more frequently than not. So, yeah, I mean, it's a definite question I have in my head, because I do advocate a lot of fasting. So they just have to be mindful of meeting our needs more frequently, I think.
Good. Peter, this is Peter Ballasett, who most of you would know of, my favourite forage agronomist. So,
I'm sure that's a long list. Thank you very much for 2 great presentations. My question is about effects on the offspring later in life from that uterine environment, and what do we know about children or adults, who are coming from that experience? Thank you.
Yes, as I mentioned, I think if we want to go back to the root cause of disease, you have to go right back to the embryo, and that doesn't get more root cause than that. So the effects long term are that when I mentioned the pancreas has to start to produce insulin in that last part of the first trimester, if it's exposed to a lot more maternal sugar than is necessary, the size of that pancreas increases by 6 times. So more than what it was meant to be destined to become. So we know that the offspring of these women actually are at far greater risk then of themselves developing type 2 diabetes at an earlier age. And that could explain why we do see earlier diagnoses of type 2 diabetes in the last 2 to 3 decades. And as well, they have this hyperinsulinemia, which also has other problems. I mean, in terms of cardiometabolic risk and the offspring, that increases as well. I think some of those big factors are also in the sense of that infants and children as well as adolescents are often larger for their size because they've actually ended up in a state of hyperglycemia and hyperinsulinemia from a very young age. And it can also change even issues with appetite and satiety, so overriding some of the mechanisms that relate to hormones which direct our satiety and fullness. So there's a lot of postulated information that's come out from epigenetics in the last decade, and it's hard to obviously go back and like we're really just making associations, but they're quite clear and they're becoming more apparent as well the more we look at mouse studies. So it's probably one area where a mouse is useful because they only live a short amount of time and we can see what happens to them. Whereas in humans, it's going to take a lot longer for us to see all those impacts on the offspring. But it's very profound, and not only just because of the maternal health, but also paternal health as well, which is increasingly becoming more of a feature when it comes to epigenetics.
Right, lucky last.
Thank you. Thank you for 2 wonderful presentations. I want to ask Nicole about monitoring muscle mass in the patients, and how do you give guidelines for resistance exercise in a nutshell? Thank you.
Yeah, well, we are fortunate enough in our practice to have a body composition analysis machine, a seeker machine. So we do on all of our clients that come through a actual body comp test. So it actually shows how many kilos of skeletal muscle and where they sit on the radar, I guess, for their skeletal muscle for age. So that's how we do it. So we're lucky to actually be able to do that fairly accurately, and we can monitor that. And if we see some of our clients are actually had a drop in muscle mass, then we have another conversation about their protein intake and also resistance training. And I'm clearly not an expert in resistance training. But we talk about them just trying to do push and pull exercises or see an exercise physiologist, because that's part of it as well. It's not just, go out, you're going to grow big muscles if you just start eating more protein. You actually have to go and do some exercise. So, we'll, maybe refer them on to an exercise physiologist or, just get them to start moving. And, in the beginning, it's not a conversation we have about exercise because they do naturally, often we see their muscle mass most times go up because they've come in on a high carbohydrate diet and then we've replaced that with more protein anyway and healthy fats. So they naturally always show an increase in muscle mass, and then they're often then ready to go, actually, I feel like doing some exercise. So yeah, to answer that, we measure it using body composition tests and just encourage them to start moving and then refer them on to someone who can help them a bit more.
Great. Well, thank you for questions, and please thank our 2 speakers. They've been really thought-provoking.